really does work. It really works on the brain in driving down your cravings and your own impulses to eat food. And that I think that's what spills over a little bit to other areas. There's other areas of pleasure in our brain, like sex. And I think it decreases some of the cravings that we have to have sex. And I think that's what we're seeing an impact with sexual function and with erectile dysfunction.
We are here on another episode of the Erectile Dysfunction Radio Podcast. Today we are joined by Dr. Rahul Mehan. Dr. Mehan is a board-certified urologist and the founder of East Valley Urology in Mesa, Arizona. He is also the founder of Snip City, which specializes in vasectomy procedures. Today, Dr. Mehan joins us to discuss Ozempic and the impact on sexual function. Dr. Mehan, thank you very much for being here.
Oh, my pleasure. Yeah, happy to be here.
Okay, so to get us started, can you just give our listeners like a little bit of an overview of what is Ozempic and what is it primarily used for, as well as there are a number of other competitive products on the market that go by other names that I believe are very similar to Ozempic, just to mention those as well.
Yeah, so Ozempic is a peptide, and it's the basic name of this is semaglutide, and this has been out for quite a bit. It's been studied extensively in the diabetic population as a drug to help with that. It goes under this class of drugs called GLP-1 agonists, which is glucagon-like peptide-1 agonists. And it has a lot of effect on the body and does a lot of really interesting things. Some other trade names are Wegovy, which is something that a lot of people get prescribed, and Ozempic. Those are the two more common. A lot of people use a compound form of it, and semaglutide is the name of that. But there's different forms of it. They all do the kind of exact same thing. It's usually an injection that people do, and then they ramp up on the dose, and it really helps them lose weight. And it's been interesting. It's been studied extensively in the diabetic population. We have really good literature, and we found other benefits other than just weight loss. It helps with blood sugar, it helps with cardiovascular health, it helps with kidney disease. It's kind of interesting. All the specialists in my hospital sit together and have lunch, and we all talk about it and how it is really helping all of us. It's recently received FDA approval for the chronic management of weight in adults classified as obese or overweight with at least one related obesity condition. So we have kind of a new indication that people are taking it not just for diabetes, but as you know, for weight loss. And in the West, in Arizona, if I go to California all the time, it's like trendy. They have all these celebrities on Ozempic, on the semaglutide, and people are just losing losing a lot of weight and looking at it. And it's really interesting to see how it impacts people from a sexual function, from their sexual health, and that's what we're talking about today.
Exactly. We're gonna get into that, but like you're saying, there's so many aspects to this drug, which like makes it very, very like fascinating and very promising in a lot of ways, but also very complex to understand. Like, what are the impacts and outcomes when it comes to things like sexual function? So, just to give myself and listeners a little bit more knowledge here. How exactly does Ozempic work? I understand that there are, GLP-1 agonists for us non-medical professionals. If you could give us a layman's explanation of what this medication does to people in terms of managing blood sugar and weight and whatnot.
For the pancreas, how it impacts the pancreas is kind of interesting. It helps the pancreas release the right amount of insulin when blood sugars are high. And insulin helps move sugar from the blood into other body tissues where it's used for energy. So it helps in that regulation of insulin release. And the pancreas is an organ that makes insulin. So it really targets kind of the front end of the whole process when it comes to metabolism with our blood sugar and how that's released and how that impacts our body.
Okay, and you said one of the I guess was becoming a more primary use of Ozempic and other drugs in that class has to do with weight loss. Does that explain its I'd say recent in the past couple of years popularity? is like primarily now as a weight management and weight loss drug.
Yeah, it's interesting too. So the other effect on the body, I'm going to go back just to answer that. This drug connects with these GLP-1 receptors in our body and our pancreas, which helps with, as we talked about, with how our body produces insulin and metabolism and whatnot. But it also connects with our brain in some level, and it increases our sense of fullness. It decreases our drive, our impulses, our cravings for food. So a lot of people get these drugs and they're just not hungry. I've had a lot of personal friends on. I prescribed GLP-1 agonists in my practice for a couple of years since it came out. I do a lot of health and wellness with urology. And there's just a lot of patients that just can't lose weight, and they want this extra benefit to help. And it really does work. It really works on the brain in driving down your cravings and your own impulses to eat food. And that I think that's what spills over a little bit to other areas. There's other areas of pleasure in our brain, like sex. And I think it decreases some of the cravings that we have to have sex. And I think that's what we're seeing an impact with sexual function and with erectile dysfunction.
Okay, so that's what I was going to be like curious about. And so just to kind of like back us up here for a little bit. So the mechanism by which people lose weight, is that primarily by I don't know if suppression is the right word, but is that by a dampening of cravings, a dampening of that impulse to eat, right? Or are there other mechanisms going on inside of the body that also are contributing to weight loss? Meaning, is this primarily like psychoactive, or is this?
No, there's two. It's the psychoactive mechanism where you just feel less hungry and you feel more full. And two, that's actually helping lower your blood sugar levels. Like, this is a diabetic medication, and it's regulating those levels and keeping them down, which has an impact on how we metabolize and how we utilize the things that we eat.
Okay, and as far as you're aware, are those two effects unrelated? In other words, they're both coming from the medication, but does this happen to just be a side effect of a blood sugar regulation medication that also is cutting down on cravings through its like psychoactive effect or its impact on the brain, right? Or is
Now,
there like, yeah.
great question. You actually have GLP-1 receptors that are located in the gastrointestinal tract, in the pancreas, and also in the brain. So it's going to these different organs. And now we're finding out there's a connection with the kidney, and how this impacts the heart. So that's the question. And this whole podcast, I think the real question for me, and as all urologists, when you look at this, I was just talking to a urologist this morning. I go, did you know that men on these drugs have lower levels of testosterone, and they also have erectile dysfunction? It's not a huge number. So the study that we're referring to came out in November of last year, and it was actually a really interesting study. They looked at this TriNetX research database, and they looked at 3,500 men who were on Ozempic, and they had a control group, and then they had the group that was on it, and they really got rid of all patients that were already on, that had erectile dysfunction, that were on PD-5 inhibitors. They looked at people who had prostate cancers with radiation and surgery. They looked at people with pulmonary hypertension. They got rid of all those people. They excluded them, and then they compared people of the same age, the same race, same BMI. They had hypertension, if they had sleep apnea, if they had hyperlipidemia, and they looked at a control group and then a group on semaglutide or Ozempic. And the people that were on it, and this is ages, I believe, 18 to 50, so these are just kind of young guys, only 1.4% of them developed erectile dysfunction. So it's not a huge number. This is not like, hey, you're going to be on Ozempic, you're going to have erectile dysfunction. It's a very small number, 1.4%. And those are men that started PD-5 inhibitors, started Viagra and Cialis once they started taking Ozempic, versus a control group, which is 0.14. So there's definitely a difference there. And this is early on. This is a small series. This is not like a massive study. When they looked at hypogonadism or low testosterone, they found that the control group was about 1.7% of patients started testosterone replacement therapy. And then with the Ozempic arm, with semaglutide, it was 3.83%. So there it's definitely, there's a change there. And then when you go to like Reddit and you start going online, it's all these like accounts of like, hey, dude, I started Ozempic and now I have erectile dysfunction, and it's crazy. So, maybe there's a direct effect on things, maybe there's not. But what's interesting in the urology space is we've known for years, if you lose weight, your testosterone goes up. There's this European male aging studies that looked at this. If you lose 10% of your body weight, you can see 100-point increase in your testosterone. If you lose 15% of your body weight, you can see almost a 250-point improvement in your testosterone. We see this in the bariatric literature. When people lose massive amounts of weight, their testosterone goes up and their sexual function goes up. When you have better testosterone, your sexual activity goes up, your sexual frequency goes up. I mean, it really helps in that department of libido and drive. It's interesting. It's the opposite. These people are losing weight, they're having erectile dysfunction, and they're having hypogonadism. Which why?
Yeah. So to that end, do we know what the mechanism is? Do we know why testosterone levels are lower? Is there a direct, like, linear link that we can see the impact of a medication like Ozempic, what it does in the brain, right, and how that might affect release of testosterone? Or have those links not been well established quite yet, leaving us with, again, the possibility that this is something which is more psychogenic, in the sense that a generalized suppression of pleasure, right, can lead to just less thinking about, things that are of sexual nature and whatnot, that could trigger a decrease in production of testosterone in some of these men. Like, do we know what that mechanism is at this point?
We don't. And we're speculating as urologists. There's just not good data out there. There's not a lot of papers. And I think a lot of people are looking at this and really excited. It's very, very interesting, because there's just so many millions of people on these drugs now to help them lose weight and regulate. Obesity is just an epidemic in our country and throughout the world. And I think these drugs are becoming much, much more affordable and easily prescribed than they've ever been. But I think it's more than just a mental aspect. And the one thing that I think is really interesting for me as a urologist, I'm always looking at body composition. When I put people on testosterone replacement therapy, a lot of the time it's because they can't maintain muscle mass. And with these drugs, and you lose weight rapidly, there's reports that people are losing muscle mass rapidly. And maybe that's a connection with low testosterone, and a connection with erectile dysfunction, although we don't really know. And I would speculate that for me, when I see a lot of patients that come into my door, especially younger guys in that age group, under 50, who are starting on Ozempic or these GLP-1 agonists, I really want to look at their body composition and get a picture of where it is and see what happens. If they start losing muscle mass, put them on testosterone. That's a symptom. Check their testosterone levels. If they're low, put them back on. I think that combination is very important to look at their overall muscle mass and their physical well-being when you put them on those drugs, and see what happens to them.
I have so many questions. This is like such a fascinating space. So in the study that you mentioned, did they look at anything else beyond erectile function? Did they look at libido, frequency of engagement? Because, when I know this, I'm sure you know this as well. When you ask somebody just about erections, you're oftentimes not getting a full picture. So, like, if somebody's like erections have like wax and wane, their drive is down, like, it's not like something they want to come out and they would necessarily fill out a questionnaire and admit to right away. But when you kind of get into the nitty gritty, right, and you're talking about a drug that has the potential for suppression of impulse and drive and whatnot, do we know anything about like just general like satisfaction with sex, frequency of sex? Has there been like a study that's examined like what actually happens to a person's like sex life, right, and drive towards sex and satisfaction with sex from their baseline to where they are post or peri use of Ozempic?
There's not. So in the study that I referenced, all they looked at, the endpoint was, did they start Viagra or Cialis? Were they prescribed that in that time period? And unfortunately, I don't think a lot of doctors really do a deep dive in their sexual health and really see and ask those questions. And those questions are spot on. You really need to know what's going on. Because it could be just lack of libido, not their ability to keep an erection. And they're seeing the doctor, and the doctor says, "I'll just take some Viagra, you'll be fine." That's not going to address the issue at hand. Their issue is much more complex than just putting them on things. And the other thing that for me too, when I look at this, if it is really affecting these pleasure centers in the brain and it's really inhibiting them and you're just not craving sex, that's not just affecting men, that's affecting women too. And we talk about HSDD, which is a hypoactive sexual desire disorder, which is very common in younger women. Is that increasing too with these drugs? We haven't looked at that either. And is this something that, and I as a urologist, I'm treating both men and women. When I see somebody on one of these GLP-1 agonists, Ozempic, Wegovy, you really want to screen and not just look at overall, erections, but really talk about their sexual health together, and really look at that.
So this has to be a very complicated space to tease things out, because a lot of people who are going to be pursuing these drugs because of a desire to lose weight likely have not been feeling great about their bodies in the first place. So their baseline may already have been HSDD. So even as they begin to feel better about themselves, they may report no change, but the piece which is contributing to that low desire may have shifted. In other words, like if somebody doesn't feel good about themselves, like they may start to feel a lot better as they lose weight, but now they have this drug which might be suppressing pleasure-seeking activities and drive. And I can imagine this is very, very hard to tease out and figure out without there being almost like a before and after study that's like specifically designed to target like these aspects of sexuality, because it is so multifactorial. We don't really know what we were starting with. It's really hard to know what's coming out. So just going to go back to the previous study. Also, you mentioned that this is measured by new prescriptions of a PDE5 inhibitor.
Correct.
Okay, so it's the same problem. It's the same problem because if people were not sexually active before, even if they're in a long-term relationship, a lot of relationships kind of atrophy in this department. There's no reason to assume that things would pick up. All right, so those might be like missed opportunities to track. Like, did somebody develop erectile dysfunction as a result? Well, if their function wasn't good before, or they were not really active, they're not going to report very much, right? Or they're not going to ask for that prescription, making this very, very complex.
Yeah, another thing, you just talked to like the guy on the street, like, well, dude, they were obese before, they weren't, they weren't like, they were ashamed, they're there's all kinds of reasons that could be a barrier for sexual function. And when they get their confidence back and they lose weight, they're like, hey, I want to get back in the game, and they get prescribed the drug too. So, I mean, it's not the best study. I mean, but it's like the tip of the iceberg. I think we're just learning about the interaction with these drugs and how they affect sexual function.
Yeah. And like you pointed out, there are millions of people around the world who have used or are using and certainly will use medications and drugs of this nature. So there should be opportunities to further study this down the road. But there's just a lot of layers of complexity here, because there are factors that should contribute to like people feeling better about themselves, and like with the loss of weight and better control of blood sugars, you would expect there to be better blood flow. There'd be like reasons why like erections would improve. At the same time, if this drug is also suppressing pleasure, right, you're kind of getting a mixed bag of factors going in different directions. It's really, really hard to tease this out.
And I think this is a wake-up call to providers. Like, you really need to do a better job. We need to do a better job screening for sexual health in patients, especially patients that are on these drugs. I mean, we need to screen men for hypogonadal system symptoms in addition to erectile dysfunction. We need to screen women too for HSDD. We need to look at their their muscle mass, and if you have an in-body scanner or some means to look at their muscle mass before they start Ozempic or any of these medicines, and follow them through the process. If they're losing muscle, check the testosterone level, put them on testosterone, be aggressive in that. I think you're going to really do well in helping patients in a better way.
I think in years to come, hopefully we'll have a better psychological profile, right, of the before and afters of Ozempic, not just around sexual function, but just around so many other areas: body image, self-esteem, confidence. All these pieces do factor into healthy sexual function. So like I'm hoping that there will be forthcoming data about these medications, as they are so very prevalent. So I'll ask you a hypothetical. If a patient comes to you and they're visibly overweight, their BMI certainly puts them into an obese category, and they like present as like the only thing that's really concerning them is sexual function. We'll call it erectile dysfunction. They're not necessarily interested. They're okay with their body. They feel okay with that. Would there be a place or a time that you, as a sexual health and sexual medicine expert, would consider Ozempic as part of a strategy to, I guess, try to help this person get to a better physical state where erections would flow more naturally? Or would Ozempic not really be part of a treatment plan and we would be looking at other, let's say, more traditional routes of trying to address erection issues?
No, it's absolutely part of our toolkit, our tool bag. We pull this out. We need to. Like we as urologists, if we focus just on arterial flow to the penis, we are missing the boat. There's so much more to it. When if I get a patient in that has erectile dysfunction, I want to know why. And why, it's not testosterone driven. You have to look at everything. You have to look at, are they obese? Are they diabetic? Do they have hypertension? Do they have high cholesterol? Do we screen for those things? If they're abnormal, do we send them into, back to their family doctor? If they have cardiovascular disease, do we send them to a cardiologist early? I mean, this is the penis is a barometer to our overall health and how we're doing. And it could be a warning sign. If somebody comes into erectile dysfunction, it could be underlying cardiovascular disease. So like if we don't do the screening, we need to get patients into a family doctor that's going to do, check a hemoglobin A1C, check your cholesterol, look at your blood pressure, do that general workup and see what's going on, because we're doing that patient a disservice if we just give them Viagra and wish them well. And if it's a weight related issue, and that weight related issue is part of one of those metabolic conditions, this metabolic syndrome that people have, definitely these GLP-1 agonists have so many health benefits. And then we layer on what we do. We put them on Viagra, Cialis, we study, we look at why they have erectile dysfunction, and we can treat it. We have so many wonderful options to do that nowadays. But I think it's important that we do a full workup, and that's more than just handing out Viagra and Cialis, or more than just taking a testosterone. They need to figure out, what's going on. And then for all patients, diet and exercise helps everybody, especially with erectile function. You get people, there's a really great study that came out, out of Baylor, where they did a meta-analysis of all these studies of men who were put on exercise programs, and this is cardio, and they all had better erections. It worked just as good as Viagra and Cialis if you put somebody on a 30-minute exercise program 3 days a week, and they're going to lose weight, and they're going to have better erections. So we should be prescribing exercise on top of these things, in addition to trying to figure out what the underlying causes are.
Okay, so I was going to ask about. So first of all, if we can get a copy of that study, that's fascinating. I really would love to, be able to provide that to our listener base, just about the potential impact of just taking care of oneself, getting the cardiovascular system pumped up and running. That would be really, really great. Now, to that end, with Ozempic, I think from what I've learned about it, and this is really anecdotally, just from people that I work with and people around, that a lot of people feel like they can just not have to exercise, because if you are one of the fortunate people, and I know it doesn't work for everybody, but if you're one of the fortunate people where you do respond with weight loss, sometimes it can feel like you're good, like you're shedding weight faster than you ever could in the gym. And it almost feels like you don't have to do that. So generally speaking, do you recommend to your patients who are on these medications and whatnot, that this is a good opportunity to develop a healthy lifestyle around the weight loss? Or is that something that really could be skipped?
No, you have to. Muscle mass is everything. Maintaining your muscle mass and increasing your muscle mass is one of the best things you can do for longevity and improve your overall health. It's going to prevent falls. It's going to prevent aging. It's going to keep your testosterone high. It's so important, and it's easy for you. I have friends that take Ozempic, and they lost so much weight, and then they lost all their muscle, and they just feel weak and tired, and they're just not happy. And I think we're doing a disservice if we overlook that. I think it's important too to check muscle mass before you start these drugs and to follow that and really put people prescribing exercise. So in addition to cardio, weightlifting, weight training, weight bearing exercises is so important. It has so many valuable aspects, especially from a sexual health standpoint. It increases your testosterone, increases blood flow. There's just, we don't have a lot of really good, I'd love to do a whole episode on this. I love exercise. And I think talking about what we know, there's so much there in the literature looking at how strength training and weightlifting can help with sexual function.
Okay. So, I would love to have you on for an episode to just talk about like the healthy lifestyle and like the exercise and those pieces. It's a really, really, really important topic. So if it's okay with you, I'm going to pin that as an opportunity.
Yeah, I'll come back and do this. Yeah. But it all ties. It
all ties in, hey, right? It all
can't just prescribe exercise so people don't respond to it. You have people that go to the gym and they try their hardest and they hit it hard and they work on diet and they still don't lose weight. And, this GLP-1 agonist, semaglutide, this is a miracle drug for that patient. This is for patients that have serious medical conditions from being obese or being overweight. And it's going to help them lose weight. And it is necessary. It's going to help preserve their kidneys, their heart, all those things that we want them to do. But in addition, you just can't, you're not going to put on muscle mass. And if you waste away, you lose your core muscle mass, that you're doing a disservice to patients. And that's been in the news the last year. It's very, controversial, but it's important. And it's also important during those times too, to screen for hormonal health and screening for sexual function and making sure those stay aligned. Those risks are very small. I don't want this podcast to worry people. Like, I'm not going to take Ozempic because I don't want erectile dysfunction. Well, that risk is like 1.5%. It's pretty low. And, if you have it, we're going to treat you and you're going to respond well. It's probably better for your overall health to be on those drugs if it's deemed so by your provider. If you have a good shared medical decision and you think that you should be on those drugs, and stay on them.
Yeah, the benefits of these drugs, you're saying almost across the board, are going to outweigh the costs, and a lot of the downside of the side effects are manageable, whether that's holistically or with other medications to counterbalance some of those effects. And the risk here, even based on, again, I know that study was anecdotal, and I know Reddit might give you a very different prescription, different picture, but I will remind people, most of the time when people are posting on Reddit, it's because something went wrong. So it is skewed, right? It is a little bit skewed in that sense, and that's not really a good metadata analysis. So things can go wrong. But again, if you are under proper medical care, almost all of this stuff should be addressable, and there should be a way to find a regimen that both promotes overall health and can help keep your other systems, including sexual function, moving in a generally positive direction.
100% agree.
Okay.
That's beautiful.
So I just want to kind of come back to the muscle mass piece, just so our listeners can better understand. So what is it that occurs that people lose muscle mass? I kind of, when I think about weight loss, I just go, you're going to, all the body fat that I don't want will just come melting off with this like miracle drug. But clearly it's not that targeted, meaning what causes the muscles to break down if they're not being worked or exercised?
When you lose weight rapidly, your body's looking for energy stores to break down, and muscles is an easy target and is easily accessible. I do all these 3-day fasts. I like Peter Attia, and he used to do a bunch of these longevity stuff. He stopped doing fasting just because he was losing all this muscle mass. It was hard to put it back on, and he found it very difficult. And I've seen that in my life too. I used to do a 3-day fast every quarter, and I would lose an insane amount of water weight and muscle mass during just 3 days. It's amazing how quickly muscle will go away if you don't exercise and have protein. The thought with the GLP-1 agonists is if you don't eat enough protein, if you reduce those cravings you're not eating, and you're eating the wrong food, and your stomach is filled, and you're just not getting enough protein in your system to maintain the muscle mass that you need. And I think for me, that's what I tell patients is like, hey, you're not going to eat as much, but when you do eat, you got to make it worth it. And you got to track how much protein you're having in a day. And really, we have a goal set to maintain the muscle mass that you have. It's interesting when you go to the supermarket now, they're having food that's packaged in smaller amounts and marketed to people on Ozempic because they're not eating these big packages anymore. They don't need to go to Costco and get a big thing of ground beef because they can't eat it.
Dr. Mehan, it's such an important point that this really, like, if people are taking this for weight loss, it really should be looked at as a piece of a larger lifestyle change or shift, because again, up until this podcast, my impression was, well, you go on Ozempic. I understand that you have suppression of appetite to some degree, but like, just you can eat all the pizza that you can possibly fill until you're contained, and then it's not a big deal because you're just going to lose the weight. But I think what you're highlighting to me, and hopefully to our listeners as well, is that like, yeah, this medication can help you lose weight rapidly, which is great, and it can have tremendous amount of health benefits. But one of the downsides is like, you need to have a way of replenishing like what your body needs to maintain basic muscle mass for your health, and that means like having a protein heavy diet in conjunction with this medication, because there's only so many calories you're going to take in before you feel full.
It's a full-time job to do that. And you can't just eat all your protein in one meal and be like, I'm good. I mean, you got to strategize. You got to meal prep. You got to be, like you go to work, you got to have the right thing with you. And it's a lifestyle change. If you're going to be on Ozempic and you're going to do it right, I mean, you got to layer in exercise. You got to layer in nutrition to that, so that your body, doesn't waste away.
Okay, that is really, really, really helpful to understand. Now, in your experience with patients who are on Ozempic, outside of erectile function, okay, have there been any other, let's say, consistent reportings? Meaning, obviously, when you have a lot of people on a drug, there's going to be all kinds of reporting, at least in small numbers. But has there been any other findings that your colleagues, the general urology field have noticed when it comes to like sexual function, sexual health, and drugs like Ozempic?
Yeah, and I think there's definitely a decreased amount of impulse, libido. People are more. I had one patient that came in there, and his wife calls him boring now, because he's just, he's not like engaged as he was before, and as interested in sex. And he had low libido, he had low testosterone, and I put him on testosterone. He got better. His libido got better. His drive got better. So I mean, there's a reason for all this, but I do definitely think the impact on the brain is, there's much more to it than we know. And I think we're the tip of the iceberg on how this is impacting, our sense of pleasure and fulfillment.
Yeah, and I want to just make this point to the listeners here, that even without a medication, I've encountered this on several occasions when people make lifestyle changes that are meant to like make them healthier, but that does come with pleasure reduction, that can have a broader impact on the mind. And sometimes when people like go for a like lifestyle overhaul, which absolutely I'm supportive of, and they should and whatnot, it is also important to be aware that when you reduce pleasure intake, if you're not going to make adjustments in other areas, you could like fall into almost like this like pleasure fatigue, right? Where you're just not seeking pleasure. You're much more utilitarian because you're on a mission, right? You want to lose weight, you want to feel better and whatnot. So I've worked with several men over the years where things like this have occurred, that they just had a general reduction in pleasure seeking in other areas of their life that did kind of spill over. Once they were aware of it, they were able to make adjustments just in terms of how they were approaching sexuality and sex with their partners, that were able to make a difference. So I don't know if it's just unique to Ozempic as much as it is that when there's a broad like effort to reduce pleasure in areas where previously you were experiencing a lot of it, it may have other downstream effects, which kind of brings us back full circle to where we were at the beginning, which is it is really hard to tease this out in terms of what is medically or medicinally driven here and what is like psychogenically driven here as a result of some of the effects. So I find this like a tremendously fascinating space and whatnot. Dr. Mehan, is there any like concluding words that you would give to our listeners who are either on Ozempic or considering Ozempic as part of a broader lifestyle change?
Yeah, if you're overweight and you're concerned, do it. Talk to your provider. Look at it. Find out, screen yourself for everything. I mean, there's so many people, especially men, that don't seek medical attention ever. They never see a doctor. So, I mean, see a family doctor, get checked out head to toe, looked at, and if this is part of your medical plan and this is deemed necessary, do it. Like, I mean, it's life changing. The people that I've seen that have lost a lot of weight and, it makes a huge difference. And these drugs not only help you lose weight, they're going to help, with your heart. You're going to have less risk of cardiovascular disease in the future. You're going to have safer kidneys. You're going to have all these things that we're finding are really interesting. But during that process, if you have any concerns with sexual function, get it checked out. And as a provider, we need to screen men and women for their sexual health when they're on these medications. And that should be a red flag to ask even more questions. Really, how are you doing? How's it going? For women, I think, hypoactive sexual desire disorder has a connection to this at some point too. If we're decreasing pleasure zones in the brain, that may be affected. And for men, we definitely want to screen for hypogonadal systems, for symptoms of low testosterone. We want to ask men and see how they're doing, talk to them about their sexual health, and really do much more of a deep dive than I think we're doing now. And it's super complex. I mean, I wish each of these. I wish as a provider I had an hour to spend with each patient and to go over everything. And unfortunately we don't. So I think it's really good for podcasts like this where patients can start looking at and making a checklist of things and start looking at things and checking things off and have questions to ask their providers. But if you're a patient and you want to start Ozempic, do it. If you want to lose weight, do it. And do it through all means: exercise, diet, sleep, stress reduction, be in a good, healthy relationship and develop that. Have a support system. And then, get checked out medically. You want to rule out everything you can and optimize everything you can, and then start one of these medications and stay with it. These medications are easy to start and easy to stop. I have a lot of friends that, they get it, they get a little nauseated, they have like gas, they have some GI disturbances when you take these medications. And instead of just backing it down, they just go off of it. And that's the thing. You go off these medications, you put that weight right back on. So this is a lifelong medication to be on. That's another thing to keep in mind. And we're going to have more and more literature and data looking at long-term what these drugs are doing. Yeah. And we don't know yet. So it's interesting.
Dr. Mehan, thank you so much for joining us. This is super informative. I am going to reserve a spot for us to address the diet and exercise piece in and of itself when it comes to sexual function, healthy being, and erectile function in particular. It's an important topic. We get asked a lot about it, but it is one that is not my area of expertise because it pertains a little bit more to the body, although obviously exercise has a very well documented impact on the brain as well. But I would like to have you back on in the future to bring your expertise and let our listeners know some of the things that could be particularly helpful, not just to addressing erectile dysfunction, but also for maintaining a healthy body and a healthy lifestyle for healthy erections moving forward. So once again, thank you very much for your time.
My pleasure.